I'm going to go ahead and call the meeting to order. This is the Behavioral Health Subcommittee of the Incarceration Prevention and Reduction Task Force. Today is Tuesday, November 15th. It's 9:02 in the morning. We have a quorum here, and we'll go ahead and get started. And Perry Mowry is going to read the land acknowledgement statement.
Thank you, Mr. Hamill. Before we begin, we acknowledge that we are gathered on the traditional and unceded territory of the Lummi, Nooksack, Samish, and Semiahmoo people who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respects to their elders, past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us together here today. And please join us in uncovering such truths at any and all public events.
Thanks, Perry. Brian, can you go ahead and read the first item on the agenda?
I'm sorry, I cannot find the email with the attachments. Wait,
No.
Wait a minute. Here it is. I'm sorry, I still can't find it.
That's
somebody else do it, Barry?
Yes, our first item is to develop solutions to alleviate the behavioral health workforce crisis. This is continued from October in discussion.
Okay, thank you. Stephen, since you were part of that work group, can you go ahead and describe any actions that were taken between last month's meeting and today?
There were no actions, Dan. I just was recalling something Jackie Mitchell mentioned to me that she thought a work group had been formed. I was going to email Jill and have her try to convene a discussion. Jackie and Perry and I have also talked about, well, they invited me to participate in a meeting that they had called with the behavioral health providers in the community to talk about Medicaid rates, capacity issues that they're experiencing. And I was going to try to at least include in the discussion the kinds of discussions we've been having here in the committee. So that meeting is happening this afternoon at 1 o'clock. And with Perry's capable facilitation, I'm sure we'll have something to report back from that as well.
Okay. So to be decided, basically?
Yeah. In development.
Okay. Does anyone else want to chime in on that?
Go ahead, Brian.
Oh, I was just saying, I think I can join that meeting. That would be interesting. I have a few ideas.
Perry, you're going to say something?
Just adding to what Stephen had shared, the meeting today is really stemming from the original work of the behavioral health gap analysis team as we updated the sequential intercept model. And a number of the recommendations that came out of that SIM update were oriented around addressing the need for further services in the community. Those services are obviously provided by our many behavioral health providers. And so it was our interest to bring them the information to make sure that folks in the upper structure of the behavioral health providers had that information from the sequential intercept model, including the needs and recommendations that came from that, and then speak with them about a number of different components, but essentially, providing that information to them and having some discussion, and also being able to gather information just in regard to the challenges that they are facing relative to workforce gap and capacity, which is the first piece that we really needed to know in order to support these groups relative to reaching those recommendations, needs and recommendations that were identified. So we wanted to pull them in, initiate further discussion, and answer questions too in that regard. So I just wanted to update a little bit about what our goals and intents were for that meeting today.
Okay, so I take it the group will then report back to the behavioral health subcommittee at the next meeting. Is that correct?
We'll be happy to do that.
Okay, sounds good. Anyone else want to report in on this or chime in? Okay, seeing none, then we'll move to the next item. Perry, can you just go ahead and read the agenda?
Dan, Jackie and Courtney had their hands up.
Oh, I'm sorry. So I can't see any of this on my phone. This is making it like really impossible to see. Jackie, go. I don't know who was first. Jackie, go ahead.
Yeah, I just want to make sure. I think we did develop a work group. I think Mike and Arlene both maybe said they wanted to be on it. So, but I wanted to make sure that was official from maybe that was from the Legal and Justice Committee, Stephen. I don't know. But I think we need to get a chairperson too, so we can start convening meetings. And so, Jill, do you remember if it was this committee or the Legal and Justice Committee?
I'm wondering if maybe you guys did it in steering committee, just informally. I don't have any notes on a group, but if you guys want to form a work group, that would be great, as long as there's not a quorum of either this committee or steering committee, and then you guys can just meet whenever you need to meet. Similar to BGAT, how BGAT functioned, I think, Jackie. Does that work for you?
Yep, for sure. Okay, that's great. If we can just go ahead and meet, then we'll just do that.
Okay. Courtney?
Hey, sorry, I'm a little sick, so my voice is a little hoarse today. I just had a question for Perry about that meeting with behavioral health providers. Will frontline staff be invited? I'm wondering who is invited to that meeting, because I think it would be very crucial to have frontline staff at that meeting, and not just program administration.
Our intent, Courtney, in this particular meeting was to meet with program administration and to speak on higher level issues just in regards to their capacity, expenditure of funds that have been received, and also anticipation of increase for the Medicaid increase. And so we intentionally had included individuals that were in a administrative capacity for that meeting.
Okay, I hope at a later date there can be another one with frontline staff involved. Thank you.
Yeah, I appreciate that. We also have an upcoming, it's a bi-monthly behavioral health crisis services meeting that is actually occurring on this Monday. I think you've been invited. Let me know if you have not been, but it includes line staff, clinical supervisors, and oftentimes administration from behavioral health and crisis systems as well.
Okay, anything else germane to this matter that we need to discuss? Okay, seeing none. Perry, can you go ahead and read the next item?
Sure. Our next agenda item is draft committee year-end report and 2023 priorities for review.
I can take this one. If anyone would like me to screen share, please let me know. Otherwise, I'll just do a quick readout of the items in the draft report. This is just the simple year-end report for the county council and executive, reporting on what's been done the last half of this year and what the plans are for next year. The two sections pertaining to behavioral health committee is, of course, this committee and also the joint meetings that are held with legal and justice. So I'm primarily interested to hear from you guys today on what plans you have, you would like to see this committee take up in 2023. I have two items currently. One, as we just discussed, develop solutions to the behavioral health workforce crisis. And two, continue to monitor alternate response program data. That's for behavioral health committee. For the joint meetings with legal and justice committee, the what's next for 2023 items that I have are to continue monitoring the progress of various programs and services. Also to work on reentry, existing services, needs, and gaps, and that's going to be an outgrowth of the work of the BGAT and the SIM that the IPRTF adopted. And then, of course, competency evaluation and restoration issues, as that's a big issue for the Legal and Justice System Committee as well. So if there are any other items that I've missed in the year-end report that you would like to include just a quick little blurb on, let me know.
Team, what do we have? Anything else we want to add to that?
Can I just ask a question about the 2022 update program review strategy and metrics for Grace and Lead? We've already done that, or that's
Right, 2022 update, that section, Brian, is for items that were before the committee in the latter half of this year, after the annual report was submitted in June. So it's just a quick little summary of the discussions that have already been held in committee.
Oh, I see. Okay.
Brian, does that answer your question?
Yes, I think so. So just another question. So monitor alternative response program, this would be the co-responder. I mean, all the different alternative response programs going on in Whatcom County.
That's correct, yes.
Okay.
Okay. Any other questions regarding this? I don't see any hands raised. Okay. Jill, do you have what you need?
I do, thank you, everyone.
Okay. And I believe the next item is co-responder. Is that correct, Perry?
It is mental health deputy and co-responder programs, updates from Under Sheriff Chadwick and myself.
Okay. All right, take it away, gentlemen.
Doug, if you, I don't want to jump in front of you. If you have information, I also was requested to share some highlights from the 2023-2024 budget relative to behavioral health funds, and that's not directly related. So I can do that at the end.
Okay.
Okay.
I'll just kind of give an overview of where we're at with our behavioral deputy program. And I think one of the items, I don't have it in front of me, was our staffing and kind of plans moving forward. So the sheriff's office still continues to staff 2 behavioral health deputy positions. We know that one of them will be retiring early next year, I believe February or March. So the plan will be once that vacancy occurs, we will put that back out and hopefully fill that with somebody else that is interested in that position. But certainly we see the value in the program. And again, the sheriff's office currently is the only law enforcement agency in Whatcom County that is operating some kind of deputy officer that focus specifically on behavioral health. Specific to the co-responder model, obviously we've been working with the health department on getting 2 behavioral health specialists that will be tasked to interface with the sheriff's office, and not necessarily just those 2 behavioral health deputies, but really they can ride with any deputy. So I know there were some discussions early on. Well, what happens if those deputies aren't working, or they're on vacation, or they're on some type of other medical leave or something like that? So we don't have it. So it's strictly set to ride with them, putting those resources in the car with the deputies so that they can arrive on scene at the same time, and then make an initial assessment, render the scene safe, and really deploy whatever resources most appropriate at that time. And that obviously can evolve very quickly. So having both those resources on scene at the same time, we see as a definite benefit. And then, like I said, I know, and Perry can probably update me and update the group, but just checking in, we had hoped to have those behavioral health specialists hired by, I think September was really the goal we were looking at. I know that is still posted, and not sure where that's at, but it's the same group of workforce applicants that we're looking for alternative response. So that's certainly one of the challenges we've all highlighted over the last year or two is while there's certainly a need, there is a lack of workforce to meet that capacity. So that's where we're at with the co-responder. We're still on board to have those behavioral health specialists ride with our 2 behavioral health deputies, continue that program into the future, and then also have them ride with deputies, and hopefully have their own vehicle so they can respond independently, so that you don't have two resources, that one may be not needed once you've done your initial assessment, and then the other one can leave. So that's where we're at with the co-responder model.
Can I ask a question, Doug?
Sure.
So you're hiring two people with a social work or counsel crisis intervention background. And then what would their schedule be in terms of a 24/7 shift?
So I think in the discussions we have, obviously, and similar to MCOT and some of the other programs, they're currently working, I think they're working 5/8, but I don't think the intention is to have those behavioral health specialists ride with deputies every day of the week, maybe 2 or 3 days of the week. Other days of the week, they obviously will have meetings they need to go to, probably some follow-up and casework they need to do independent of the sheriff's office. So I think we were just looking at a couple days a week with the behavioral health specialists, and as that program grows, obviously the more people they have out there, they can rotate that. I think their goal is to have 7-day-a-week coverage, but I think initially it probably won't cover 7 days a week.
And your behavioral health deputies, is that a collateral duty to patrol, or are they exclusively going to just respond to behavioral health calls?
So currently the way it's structured is they're essentially a patrol resource, but they prioritize calls for people on behavioral health crisis. So when they see that on the screen, or the dispatcher sees that on the screen, those are the units they send first. That doesn't mean that they can't be diverted to a domestic call to cover another deputy if needed. So they can handle calls. They're out there, but their primary responsibility is those mental health crisis related calls.
Could you just talk very briefly about, I attended a council meeting where they made some changes to the executive budget with 5 new deputies next year and 5 additional deputies the following year. Can you talk about how that might have an impact on how you respond to behavioral health per se, in the sense of would the 2 behavioral health deputies be allowed to maybe just focus on that? I'm talking about in later 23 or 24, when you have a few more deputies at your disposal.
Sure. No, that's certainly the goal. We've got, a lot of, we've got traffic units, behavioral health, other units that are out in the field and can respond to any type of call, but they focused on whatever that specialty is, as long as they're able to do that. When our staffing is low, sometimes we have to reallocate those resources or have them respond to other type of calls. So if we can add more deputies, yes, the intent is to be able to, have those behavioral health deputies focus solely on that function, so that they're not being called away to handle a burglary in progress or a domestic violence call, something like that. But certainly if they're in the area and they're close, especially when it comes to life safety, they're going to respond until other units can get there.
Thanks, Doug.
Other
So
questions?
I can add just a little bit more information just relative to status of funding and staffing level relative to our behavioral health specialists. As Doug had mentioned, if folks will recall, what we did was applied for through an RFP with the Behavioral Health Administrative Services Organization, and we're the successful applicant for that. That was noted back in March of this year, and that funding was to include 2 behavioral health specialists, and Doug, described their involvement and interaction. So that funding was granted. It went through council and was approved. That would cover the cost of 2 behavioral health specialists. And it does renew annually. It also covers travel for them, as Doug had mentioned, if they are not deployed with the deputies themselves, office supplies, radios, and administration. We have been, as was referenced, involved in interviewing for a number of positions for behavioral health oriented and skilled individuals within the response systems division, and actually had a pretty good response of some very capable individuals. This included vacancies for the GRACE program as well as the LEAD program, and our alternative response team, as well as the co-responders. So we were interviewing just in general. We have identified one very strong candidate for the co-responder program specifically, and have some interviews are currently ongoing. And as Doug had mentioned, those positions are posted. So interestingly, really seeing some response and some great possible candidates. And we are really fortunate, in my opinion, to be working with the behavioral health deputies. They're knowledgeable. They are engaged in a number of different meetings and the other programs within the response systems division, and honestly have some great insight into challenges that we face, and many of the questions that they ask are really, something that's taken into consideration and worked with through their input, just in regard to smooth transition into developing these programs. So, so that is on track, and we are hopeful for a second strong candidate. We take a lot of steps to really get a sense of how the individual would work with a law enforcement setting. And then there is, processes and discussions of obviously specific training for these individuals, just in regards to safety and steps and processes there. So it's been a great collaborative effort. I've certainly appreciated it, and Deputy Bauman and Deputy Klicks are always willing to show up, respond, and offer input. So it's been a really enjoyable experience for me, and I know that it has been for others. So that is our current status as far as funding and staffing level from the behavioral health specialist position.
Okay, any questions for Perry or Doug? Okay, I don't see any. Doug, I'm wondering, do you know your call volume overall? What those numbers are?
I don't specifically for the behavioral health deputies.
No, well, it's kind of a two-part question. One was like overall call volume for the department, and then what percentage would then go to or be diverted to the behavioral health people?
Yeah, I don't have those, but I could certainly probably get those within a day or so and send them out to the group. So I'll just pull overall behavioral health related calls for the agency, and then specifically for the behavioral health deputies.
Okay, thank you. All right, any other questions? Okay, I don't see any hands. All right, Perry, what's the next agenda item?
Well, so Dan, one of the sub items within this section of the agenda was highlights of proposed 2023-2024 budget on increases in behavioral health funding and staff in the health department. Now that was under the category of mental health deputy and co-responder programs, and so I interpreted this just a little bit, and I do have some information just sort of separate from this particular topic and discussion, but related to ASRs that were submitted for additional funding relative to the behavioral health program fund. I don't want to confuse things, but I have that information if that's what's being pursued. I wasn't honestly certain of what was being asked of me relative to that information.
Jill, do you have a handle on that?
I'd have to go back and look at my notes. Someone asked for an update on these items.
Yeah, it was me.
Okay.
And so I got the impression that in the budget for the health department, there was like the number, like either 13 positions, or there was a pretty significant increase in funding just in general. So I was just curious where that was occurring.
Understood, and I can share a little bit of information. I don't have it necessarily corresponding to full positions, but maybe I can share this information. And if there's some additional information that's needed or requested, I can certainly do a bit more research. As I think folks are aware, Health Department budget was submitted to County Council. That is currently in the works. My understanding, I'm not directly involved in that, but my understanding is that is, the hope is for approval pending on November 22nd. That full Health Department budget will be hopefully approved or amended as necessary. Relative to the Behavioral Health Program Fund, and what I pulled was new referred to as ASR service requests to the Behavioral Health Program Fund. There was a total of 1, 2, 3, 4, 5, 6 of those that were submitted. I'll briefly touch base on those. One of the ASRs was actually for a cost maintenance request for the triage grounds maintenance at a total of $10,000. The next one was a response systems division's vehicles. Doug had mentioned that, you know, for example, it's not limited to that, but the behavioral health specialists being able to respond to calls when they're not actually dispatched with deputy. That total request was $112,500. There also was an ASR submitted for on-site behavioral health support at supportive housing and emergency shelters. Again, I'm sorry, I don't have the exact number of FTEs that's related to, but this also included expansion of mental health court contract services at a total of $729,000. There was also an ASR that was submitted for triage facility maintenance at the old triage facility, 2030 Division Street. And then there was an ASR that was submitted for additional jail psychiatric services, was a total of $97,200. And then finally, an ASR that was submitted for medical social worker. This was actually continued funding within the jail, and that total was $62,500. So, you know, again, I can gather more information and you respond if that's put out there, if this wasn't what the committee was after as far as specifics.
That answers my concern. So thank you.
Any other questions on this one from the committee? Okay.
Perry, is it usual that the council in its final action alters those requests in some way?
You know, I don't have a lot of history with this, Stephen, but it is not typical. Usually those requests for additional services and funding are pretty closely vetted, you know, and then submitted with a pretty fair amount of information. So typically that is not altered, at least that component of it. I certainly can't speak to the larger component. Obviously, that would be Ms. Lautenbach that would be able to give, you know, that kind of feedback.
I was just wondering whether it would be worth asking you to update us after the council session on the 22nd.
I'm certainly happy to do so.
Okay, other questions? Okay, I see no other hands raised. I want to go back to the co-responder agenda item. I just have a question, Doug, in terms of the individual staff cars and responding, the behavioral health specialist responding to calls without having a sheriff's deputy along for the, you know, for the interaction. That was something that you had expressed concern about early on in the process, because, you know, these calls can evolve and change and turn into something that can be, you know, pretty, could be life-threatening or violent. And I'm just wondering how you all figured that out, or what the process is for responding to a call for the specialist. Like what are the parameters, and what's the kind of cutoff for sending a specialist versus both?
Yeah, and when I say providing them a car, I'm not suggesting that law enforcement doesn't respond as well. But the problem, and this is, some of this is based on what they're doing in Skagit County with that co-responder model down there. They have one person that's, I believe they're stationed in Concrete, so they're more east in the county, so a little more remote. They have their own vehicle, so they can respond at the same time. But if it's called that once they get there, law enforcement isn't needed, law enforcement can leave. The problem, one of the issues and one of the downsides of a co-responder model when they're riding in the same vehicle, if they're riding with our behavioral health deputies or any deputy, they respond to the call, and maybe the once it gets stabilized, the deputy can stand back, and the behavioral health specialist steps in and starts doing their work. And if they decide that the deputy's really not needed, well, they're not going to leave them there by themselves, because now they don't have a vehicle anyway to get out of there. So if they have their own vehicle, they can respond at the same time, and then the resources that isn't needed can leave, rather than wait and have both resources there when only maybe one is needed. So, but again, that's also similar to what MCOT does. They respond themselves to some of these calls. So I know those conversations are happening. I know there's putting somebody in dispatch to kind of triage those calls about what's appropriate, and that's as we talked about, that's kind of a gray area, especially for a dispatcher, because you're making a decision based on the information you receive and what people tell you, but that could change, or maybe you're not getting all the information. It's not uncommon to be dispatched to something, and once you get on scene, it's completely different than the fact pattern and the information that you receive. So that will be a challenge, trying to figure out which one are a higher level of risk to both officers and behavioral health specialists. But yeah, I'm not suggesting necessarily that they respond by themselves. That may happen. That in my mind, I kind of see a tier 1, tier 2, tier 3, and then what are those categories? But I think that will evolve over time once we get a little more history of and Mike can probably jump in. They're going to have the same thing on the medical side of it as well.
Okay, thank you. Stephen, you unmuted. Do you have a question?
I do. Thanks, Dan. Doug, how are you set up? What kind of data are you going to gather on this? How are you going to report that? At what points are you going to evaluate effectiveness or make tweaks as this rolls out? What's the evaluative piece of implementing the co-responder program?
Yeah, I think a lot of those measures will be the same as they're using for the LEAD program, the GRACE program, because again, at the end of the day, a lot of this is probably going to lead into those resources anyways. Again, this is kind of combining what we already have in existence with MCOT, with law enforcement, but we also have other areas. I mean, when they go out in the field now, they're diverting some of these folks to the LEAD program, referring people to the GRACE program. So that's going to continue. So, I see it as just part of that larger picture of the overall crisis response resources we have here in Whatcom County. But yeah, for our behavioral health deputies, I think the measures and the outcomes that we're looking for will be very similar to what you're seeing with LEAD and GRACE.
So I'll switch over to Perry. I know I see a quarterly report from LEAD. I don't see so much from GRACE. I'm wondering if there's a similar kind of report coming out of the GRACE caseload, and I never see anything from MCOT. Do we get those kinds of periodic reports on activity and evaluative criteria?
Great, it's a great question, Stephen. Let me kind of take those one at a time. The Mobile Crisis Outreach Team is actually contracted through the Behavioral Health Administrative Services Organization through their crisis funds, and they do report. They have both a voluntary and an involuntary team, if you will, depending on the level of the crisis that is going on. And so that data is provided back to the BHASO, and Jackie and I meet as county coordinators with the BHASO on a monthly basis, and they produce data from the MCOT responses, crisis responses on a quarterly basis. So we do get that information. We also are able to compare that information with the other crisis responses in the other 5 counties that make up the North Sound region. So we do gather or receive information in that regard, but because we're not contracting specifically, they don't necessarily provide that to us. We work closely with MCOT, and typically within our Crisis Stabilization Advisory Committee, as well as I mentioned this upcoming Behavioral Health Crisis Services Behavioral Health Provider meeting that's going to occur on Monday, just to connect folks and open that communication that the manager, I believe manager is the right term, of MCOT also reports out on the monthly activity that occurs, the number of calls, those sorts of things. So we do get quite a bit of input. And again, I'm really enjoying being involved with the Response Systems Division, because it is a setting of whether it's behavioral health, deputies, as we made reference to, or even providers that are out there like MCOT being involved in reporting information, challenges, needs that they have, that communication happens in in multiple meetings, but if you will, within the Response Systems Division meetings typically. There's also a requirement relative to our funding that comes through the BHASO for co-responders for gathering data. And so you can imagine it's Under Sheriff Chadwick is accurate that it is very similar data points that are reported to the BHASO, because of the fact that we obviously are administering that contract. Then we also will have that data. And I don't know how much detail I can share, but I think that we have a great advantage of the fact that we also have a designated crisis responder that is within WATCOM, the 911 dispatch. And so tracking and information in terms of those calls will also be a component of that, as well as, and we haven't talked about it, but our alternative response team. So very important to us to have metrics and data to be able to report out in a fairly simple format for community, and obviously greater detail if there are particular individuals that are pursuing a greater detail. So going to be fairly sophisticated stuff from my perspective in terms of what's developing as far as what's going to be reported through, I'm generalizing here now, all of the programs. So excited to be able to show that and efficacy and those kinds of things.
Thanks to both of you.
Perry or Doug, as it relates to what you just said in terms of the dispatch, the person that's there now taking these calls. So my understanding is, so someone calls in, there's a crisis, the call gets transferred to that dispatch person, and I might not have the terms correct, but and then that person triages the call. And so does Whatcom County Sheriff's Office use that dispatch person to kind of field the calls, or how does that work?
Sure. So Whatcom 911 is the sole dispatch center for all law enforcement and fire EMS throughout Whatcom County. So when a call comes into 911, initially it goes to a call receiver, and they determine if it's a law enforcement call, if it's a fire EMS call, and then they transfer it to either a law enforcement dispatcher or a fire EMS dispatcher. And they've got different dispatch centers Well, fire has a different dispatch center. And then my understanding is that call receiver can, if it's a behavioral health call, they can transfer it to that behavioral health specialist, and they can do some additional triage and then decide, do we send a non-law enforcement response? Is this a medical issue? Should we send, should this be referred to some, should we get MCOT? You'll hear over the radio, officers are always asking for MCOT over the radio. Because again, that's the resources that's available now to respond once they're on scene. But then they can also determine, well, let's send law enforcement and a behavioral health specialist. So that's my understanding of how it's working now. It initially goes to the call receiver, then they decide fire, law enforcement, or do we need to get that behavioral health specialist involved in asking some additional questions to assess the best response.
So is MCOT still, my understanding with MCOT is that it can be up to a couple of hours before they would respond. I think they try to do some background checking if they have the person's name, and they can kind of determine a history, and then, just be prepared, I guess. But how does that work when the deputy is on scene? And I would assume they're trying to, take care of the situation, clear the call, move on to the next one. Then does MCOT just show up after the deputies left, or does the deputy stay on scene?
So it depends on, what the level of crisis is. If it's somebody that's in, they're in imminent danger, a suicidal subject like that, they might meet the requirement for an ITA, and then they would take them into protective custody and take them to the hospital and have them seen and evaluated by a DCR there. If it's a lower level, somebody's, struggling, obviously they need additional resources. MCOT initially, their goal was to try and get on scene within 2 hours, just because of staffing. I don't know that that's happening. And then they may triage it further and say, we're going to start with a phone call, or it may be a day or two before they get out there. So it's really the assessment of those law enforcement, fire personnel. Like, what's the level of crisis? Is this somebody that is imminent risk and needs to go in to the hospital for an evaluation, because that's the involuntary resource right now? Or can we bring resources to them within a couple hours? Our behavioral health specialists, sometimes they may stand on scene. Like I said, I frequently hear over there with Bellingham Police, they will be on scene and they're asking for a call or a response from MCOT. So
For IT, is the threshold imminent danger? So it's like immediate danger to themselves or others?
immediate danger to themselves or others. And then we can, under those circumstances, we can take those folks into protective custody. And the process right now is we take them to the emergency department at St. Joe's, and they are evaluated by physicians. And then if they feel appropriate, a DCR.
So they go to one central?
Well, they start in the emergency department. There's a secure room there. And then if they make the determination, they could be transferred to one central.
Okay. All right. I and the reason I asked, Doug, is because I've had multiple conversations with prosecuting attorneys and others regarding the ITA threshold. When we have, this is maybe more of a Bellingham issue, but when we have a person who is chronically at risk to themselves because they refuse to go into a shelter, and they want to sleep outside, or it's due to a mental health illness or a substance use disorder, changing that word from imminent to chronic, and that's more of a legislative piece, and I don't know if that's even constitutionally possible, but that's been a conversation. So I appreciate the clarification on that one.
And like I said, I would say before the 2021 legislation, and you're well aware, and they made some minor adjustments in 2022. But when it came to Involuntary Treatment Act and taking people into protective custody, when officers or deputies could use force, that focus on imminent, and the interpretation from our prosecutor's office was that means immediate. That means right now, and unless you can get, that's a very hard threshold to get to. So there are people that we used to take for ITAs that we know, we're basically walking away from.
Right, right. Well, it's clear that there needs to be some more fixes in the legislative realm for sure. Other questions? Brian, go ahead.
So my question, Doug, was how does the 988 system kind of relate to what you were saying when calls come into 911? If somebody calls 988 and the person that answers, feels there should be a law enforcement response, how does that work? And how are we tracking data, say in Whatcom County, related to 988 versus 911 for mental health issues?
Sure. Well, I'll take a crack at it, and then Perry can jump in if I miss something. But 988 basically took over what we always used to refer to as Volunteers of America. If a family needed resources and they had a family member in crisis, they would call Volunteers. That Volunteers of America was kind of a one-stop. They would get the crisis line. They could get dispatched to other resources, but it wasn't necessarily a law enforcement response. That's not what they were calling for. If VOA decided that this person's in imminent danger, they would then transfer that to the 911 center. They would get involved, and then they would send a deputy or an officer to that. So 988, we still have the emergency response, and what used to be VOA is now 911 and 988. So again, 988, if they feel that it is more an imminent risk and they need, just for the safety of everyone on scene, a law enforcement response, that will get transferred over to 911. Is that right, Perry?
Yep, really accurate. Volunteers of America is our 988 number. They they've staffed up significantly relative to the rollout of 988 at this point in time. And they also are compelled to do everything that they can do with the phone call in terms of connecting the individual to appropriate services, that kind of thing. And so addressing that, on the phone, connecting the individual to the resources that are available. And that if that's not possible, as Doug had said, taking those next steps. So a lot of training, quite a few presentations that we've had from Volunteers of America relative to the challenges that 988 brings and so forth, but generally a really accurate depiction of what's going on.
So 988 has no capability of any kind of a dispatch.
To my knowledge, in terms of dispatch, they're obviously very closely connected to 911 if the call is determined at that point in time to be appropriate to be handled through that process. And I personally think that we're fortunate because, as Doug had mentioned, we're referring to the individual that is at 911 Whatcom as a community connector. This is an individual that is a designated crisis responder, that is education and training at a level and experience as a designated crisis responder within Whatcom County. And we've continued to work with the BHASO. This gets a little diluted, but try and follow the bouncing ball here. The BHASO is the one that has crisis-related funding that comes through the state, and they pay the DCRs in all of the counties within the North Sound region. So that was back when Stephen was asking about metrics and that sort of thing. That's why they get that training. Well, as we began to look at the possibility of placing an individual that was behavioral health specialist trained within the dispatch, the Behavioral Health Administrative Services Organization wanted to be involved because they are literally the ones that fund those positions. And they wanted to support and fund that position as well as actually funding a second position for obviously greater coverage and that sort of thing in the facility. At this point in time, and I haven't been directly involved with it, but the dispatch and 911 Wacom are thrilled with having that individual there, the knowledge that they have, the details that they can follow through on. And then obviously, as Doug made reference, as the alternative response team and co-responders come on, being very knowledgeable about the resources that are available, being able to determine that alternative response team is an appropriate dispatch for this particular call, thereby obviously reducing the number of calls that the behavioral health deputies or the co-responders or whomever needs to go through, essentially linking the call to the appropriate level of response. And that's going to take some work, but the organization and process at this point in time looks very promising to me.
When you two refer to VOA and now 988, is that what used to be called 211?
I don't believe so. I think that is another state program. Forgive me, Stephen, I'm not terribly familiar with 211, but Volunteers of America still exist, and they are contracted and are our 988 response folks. And as I had mentioned, I can't even remember the number, but significantly staffed up and involved in their training with this 988 rollout. And
I got that much. I thought VOA used to be the contractor for 211, which was also a referral, but maybe more exclusively a social services referral.
right, it's possible, Stephen, and forgive me, I just don't know what that connection was to, because as you said, it's more of a referral process than a crisis response process.
Okay, other questions? Okay, I don't see any hands. Perry, what's our next item?
Our fifth agenda item is items for December joint meeting with the Legal and Justice Committee.
I can take this one, Dan. Right now, there's one item on the agenda for the December meeting. The competency evaluation and restoration work group, which is a work group put together by Council Member Barry Buchanan, and includes Maya Vanyo. And so I have Maya Vanyo scheduled to give an update on the work of that work group. That's the only item scheduled currently for the joint meeting in December.
Okay. All right. I'm on that work group as well. I'm happy to share some thoughts. I was able to engage with Sharon Shoemake's legislative policy analyst person and got some further information regarding that. So I'll share that at that time. So group, committee, what do we think? What else do we want to talk about with our legal and justice systems partners? This is a really good opportunity for us to get together a few times a year and share between the two committees, which it's clear to me that there's a plenty of overlap when it comes to the things that we discuss here and the things that are going on in that committee. So what ideas do we have that we want to further discuss? See Courtney. And then Brian after Courtney.
Oh, do you want me to go first or Brian?
No, Courtney, go ahead, and then Brian.
Okay. I just wanted to circle back with, all of this conversation we're having right now. What we're talking about is managing illness and poverty, not treating it. And we have to keep talking about how we need more therapists. It's not just about funding certain other things. I mean, those things I'm not saying that those things are not needed. I just want to highlight that again. We have to have more therapists to treat people in community, and we have to have more affordable housing. All of these system response programs have become necessary because for decades, we have not invested in mental health. And I mean, returning to the point about ITAs, I mean, I can't even imagine if that language were to change, I can only imagine the other things that might change in response to that, and how the hospitals can't even treat people. We don't have enough outpatient options. We just don't have enough of anything. And so what we're talking about right now is how to better shuffle people through the system. I'm not saying that these responses are not needed. We need more community-based response systems like these programs we're talking about. But we also have to not lose sight of the fact that these are short-term solutions. We have got to start treating mental health and actually providing space in our communities for people to rehabilitate and to heal, and stop cycling them through the hospitals and the shelters and the restoration system. It's inhumane, and it's just, it makes me sick. So I think we have to highlight that again.
Okay, thank you, Courtney. I saw some hands go up, and I'm wondering, Doug or Perry, if you're responding to Courtney's comments, or if you're adding additional items for the joint meeting agenda.
I was just gonna maybe add on. We talk a lot here about mental health, but I think the other lack of capacity we have and resources that aren't available is just substance use treatment options. There's a lot of times, many of these people that, you know, the homeless community and the people we're dealing with, they have co-occurring disorders. So you can't treat the mental health issue until you really address the substance use issue. So, you know, it needs to be, we need to be increasing capacity in both mental health and substance use.
Substance use is mental health, Doug. Substance use results from trauma.
Okay. Okay, I want to create a little bit of framework around our discussion here, because these are some big ticket items, and Courtney, I have some thoughts I want to share in response to what you're saying, but I want to also respect the folks that have their hands up. Perry, so Brian, I know you're in the queue to add items, but Perry, were you responding to Courtney's items?
Generally, so Dan, I can be really brief about this. My background, although you know, training obviously in mental health, my background predominantly in terms of clinical work has been substance use disorder services, and I've often thought that one of the ways to expand capacity for behavioral health in general, but certainly mental health, is for an increase in group work. Which has not traditionally been an approach and methodology for mental health per se, and more of an approach and methodology for substance use disorder. But my point is that if a group of 6 individuals could receive services from a mental health specialist, we may be able to actually increase that capacity by virtue of the individual we're working with. Now, that would be effective for some, and it would not be effective for others, obviously, as people are aware. But it's always been sort of an interesting observation, I think, from my position of the fact that we're talking about a single clinician with a single individual and a minimal capacity. And there have been attempts. It isn't that this has never occurred, but I think that it's worth being a component of the discussion as far as capacity and workforce gap and those kinds of things as well.
Okay, thanks, Perry. I'm going to go to Brian real quick, and then I have some. I really feel like we need to reframe our discussion here, regarding these topics. But go ahead and go to Brian real quick.
I was just curious, related to Alicia Rule's request that we come up with like a list of action items. How is that coming together before mid-January with this group? Because I think we have an opportunity in December to do that. And I know, you know, Tina Orwell and many of the people that have been involved in crisis response, they will definitely have some agenda, legislative ideas. There's also, I'm involved with NAMI, Washington's Public Policy Committee, and so I'm aware of some of the things that might be happening. But in terms of the behavioral health, informing the broader committee about issues to lobby for. And also I would suggest informing the city council and the county council and the executive, their legislative agenda. What are we asking them to lobby for when they go to Olympia? So how are these things coming together between now and mid-January?
I'll take your last point first. So the city council, county council, and the Port of Bellingham have a shared legislative agenda. We work with McBride and Associates, and we have a fairly, what I would regard much more expansive list of items that we ask our lobbyists to engage with legislators on behalf of. And so housing and behavioral health are at the top of the list. There's also economic development. There's MOTCA, Model Toxic Control Act funding, which would basically provide money for capital projects. So and the list goes on. I'm not going to go into the whole thing. So there already is a legislative agenda that has been prepared and ready to go into January. To your point, Brian, about how we do this with Alicia's wish list, and it looks like she's going back to Olympia based on the vote count, and so we need to be prepared for this. Is that I think the best course of action would be for us to come up with legislative agenda items from this committee today, now, that we can bring to the joint meeting with the Legal and Justice Systems Committee, so that we're prepared to present, here's what we think we need to talk about. And what I heard was substance use, disorder treatment, service options, mental health, options for people for treatment with therapists from Courtney. Courtney also brought up housing. Courtney, I just want to let you know, and the group, last night we city council for 2 hours listened to community members, talk to us, and we engaged with on the topic of affordable housing. The limitations on affordable housing are so acute that to me, I don't see a pathway through, to be quite frank. And
I don't either. If I'm being honest with you, Dan, I'm right there with you. It's pretty bad in Whatcom right now.
yeah, and so what I want to do is, and I appreciate the discussions. I'm not, this is not like I'm not saying anything negative here, but what I want to do is make sure that what we do is doable. And that sounds very simplistic, but it's not. What we do is we make recommendations to the broader task force that then they agree or disagree. And if they agree, they make the recommendations to county council. And so that's the statute. That's what we are obligated statutorily to do as a committee. And the recommendations to county council, then what they can do is only limited within the jurisdiction that they have. So I just want to put framework around the discussion that we're having today, that we are not going to be able to solve all of these intractable problems that we're faced with, that if we just had housing, if we just had more therapists, if we just had a more just criminal justice system, then we wouldn't be in this mess that we're in right now. We don't have that, and I don't see a pathway through that unless we pick off certain things that we can actually complete or make recommendations that can have a workable outcome. And so I'm trying to reframe us here this morning to get us to a point where we can make recommendations to that joint meeting next month, where we can be productive. And I don't know if I hope that makes sense. But that's where I want to go with this, that we meet with this group, I think 4 times a year. And there's such overlapping issues within the two committees. And I want to make sure that we're productive in our time. And that's really my sole motivation. Stephen, go ahead.
Dan, I don't disagree with your framing of that. What I'd like to suggest, and what I hope we can take a small step to begin with Perry's and Jackie's meeting this afternoon. First of all, Representative Rule is an expert in this area, and she's interested in this area. So whatever the county council decides, if we can educate her and activate her on some issues, she can carry that ball independent of whatever influence the county might have or the county's lobbyists. So there's a way to leverage the weight she can throw around in Olympia during the session as well. One of the things that troubles me is when we say we want to lobby for increased behavioral health, is when you put it in those terms, you get sort of an average level milquetoast kind of fungible resource that legislators will look at. What I think we really want to lobby for is a way to address high acuity people who we're trying to divert out of the carceral system. And so you can increase the average Medicaid reimbursement rate for a master's level clinician, but those people are going to take jobs in much less demanding kinds of positions if they have any choice. So there's got to be some way for policymakers, legislators, whatever, to understand the extra challenge that our clients face, and to somehow incentivize the expansion of the workforce working with those people in programs that divert those people. And so that would be one of the suggestions I would make, is that we try to get Representative Rule to take on that task.
Do you have a roadmap for that, Stephen?
No, not at the moment, but I'm hoping a little more discussion might start to clarify that.
Fair enough. Jill, go ahead.
But you understand what I'm saying, Dan, right?
Yeah, no, I get it. I totally get it. But the problem is that what there's two competing factors here. One is government and one is market. Marketplace pays. And if the market will pay the top dollar, then people will go to those jobs and they'll start those businesses and they'll stay in those roles. Until that happens, we're stuck. We don't have the leverage. We don't have the leverage. But I hear what you're saying, and I'm not giving up. I'm just saying that the challenges are the bar is set pretty high. Jill, go ahead.
Thank you. What I'm hearing then for the December joint meeting, maybe Stephen, if you can, is update both groups on the work of this work group that you've put together. I don't know that the members of the Legal and Justice Systems Committee are aware of that. So maybe a brief presentation on the conversation with Representative Rule at the last meeting, her request for a wish list, the group that you've put together, the work that your group is doing. Is that a reasonable agenda item then for the joint meeting in December?
Well, one point of clarification, when you say the group I've put together, do you mean our committee group, that work group that I mentioned before Jackie and I were exchanging?
Yeah, that's the group. Yes.
Yes, and I hope I can rein in Perry and Jackie on that as well.
Okay. Any other ideas for the joint meeting? Brian, I see you unmuted.
Offhand, I know there is an issue related to allowing outpatient treatment for people who were in the hospital, but now they get out, and I'd have to research that more. But AOT is a big issue. But again, this is probably more of a state issue than things that the county could do on its own.
Okay. I'll throw one out. I think that we need to have just like the like a debrief or a briefing, I guess is the better word, on the 988 system. It's come up on this call. I'd like to have that as an agenda item in terms of like providing both committees some clarity on what it does and does not do. Yeah, so that's one. And I'm also vaguely, I was just considering the co-responder and ART model, since it came up today, and the ART is imminent for Bellingham and the implications of what that looks like. Courtney brought up an interesting point on changing imminent to chronic, what the implications of that would be for people in our community. I don't know that needs to be on the agenda item list, but I think that's being part of that competency restoration group. We talk about this, and there are constitutional challenges with this. Not challenges, not the right word, issues, I guess. Taking someone's liberties away from them, and hoping that you're making their situation better, but that can be abused. So I don't know. Okay, and any other thoughts from the group?
Jill, Levi Van Dyke is the director of Volunteers of America. Extremely knowledgeable individual, and has done some presentations for us in some different settings. I'm quite certain that he would respond to an invitation to present to this Behavioral Health Legal and Justice Committee. I can send you his information. I can reach out to him. We can talk later, whatever it is that you need.
That would be great. Thanks, Perry. If you want to go ahead and reach out to him and also copy me,
Okay.
and I'm happy to work with you to organize that.
And when is that the next meeting, the Legal and Justice, Behavioral Health Legal and Justice?
Tuesday, December 13th.
All right.
At 11:30 a.m. 11:30 to 1.
Got it.
Okay, other thoughts? Anything related to this matter? Okay, I don't see anything. Perry, what's next?
We are to other business.
Okay, is there other business that is related to this committee? I see no hands. Okay.
And then we are to public comment.
Okay. Any members of the public that want to speak to this committee?
Does it look like we have any attendees in the council conference room? We have one attendee online. If you'd like to speak to the committee, please virtually raise your hand now. And no hands are raised. Stephen Gockley, if you have a few minutes after adjourn to chat, I would appreciate it.
Sure.
Okay, we're going to go ahead and adjourn. It's 10:13. And thank you, committee members, for attending today, and we will see you next time. Have a good rest of your day.